Hello, everyone. Welcome. Not sure if this is working. Okay. So welcome to our implementation science skills building session. We'd like this to be as interactive as possible, so please move up. We ideally in like the first 4 rows or so that we can have a better discussion. So those of you in the back, it'll be harder for us to hear you and call on you and for you to contribute to the discussion, so please move on up. I'll just introduce myself. I'm Brian Zanoni. I'm an associate professor at Emory University in the US, but I do quite a bit of research, including implementation science research, to keep adolescents engaged in care in South Africa. And helping me out and probably going through the room to hand mics and prompt some questions is Allison.
So hi, I'm Allison Agu. I'm a professor of adult and peds infectious diseases at Hopkins in Baltimore and implement a lot of implementation science in my research studies. But Brian is the expert and I will be co-facilitating. I'm going to be a little bit more firm about this. If you're beyond the 5th row, we're not going to come back there because the microphones get all kitschy and spitchy. So if you want to be involved, which we want you to be, please come up to the first 4 or 5 rows so we really can integrate. Okay?
All right, and so throughout the session, I'm going to stop intermittently to see if there's questions, comments, thoughts. So feel free. I want this to be as interactive as possible. I do have a bunch of slides, but I'm hoping that we'll be able to stop pretty frequently. So if you have questions, we'll go throughout. And we have quite a while in this session, and we're definitely not going to take the whole time. So.
And if you don't ask questions, we may come out and ask you questions, which is great, because I think you learn by really thinking through and processing. So if I come and stand next to you and do one of these, that means I want you to hear your thoughts. Fair? Awesome.
All right, so first, a show of hands. How many people attended the implementation science session last year? Okay, not many. All right. Well, good, because I recycled a few of the slides, so not many people will recognize that. All right, so what I really mainly want to do is just go over okay, I guess next question is how many people have been involved in an implementation science study in some way whatsoever? Okay, just a good amount. Okay. All right, so some of this may be a little basic for you, but what I'm hoping to do is go through how to design an implementation science study. So I want to be very practical. So I'm hoping that you get something out of it, learn a little bit about implementation science, but then also see how it functions in action. All right, so those are my disclosures. So really what this session is going to focus on is what is implementation science, when do I use it, and what steps do I take to put implementation science into practice. All right, so first I'm going to open it up to the audience. What is implementation science? What do we think it is, and what is it?
Look at this. Go ahead.
All right. So I think implementation science is the scientific inquiry, mainly to understand what, why, and how interventions work in the real world. So particularly what you're looking at is issues to do with acceptability of interventions, how exactly you can adopt interventions into specific contexts. You're also looking at fidelity, which is the extent to which healthcare providers or program implementers would carry out programs in regards to standard operating procedures and guidelines. And I think you're also looking at issues to do with sustainability. Yeah, I think that's what I think implementation science is. Thank you.
Yeah, you hit a lot of the factors that we're going to talk about today. And a couple of the main ones to highlight is it's taking an intervention or a program into practice, into the real world, as you said. That's exactly what it is. Any other thoughts about implementation science? All right, I think you hit the major ones, but there's a lot of different definitions of implementation science. This was a systematic review done recently that looked at 69 different articles, and in 69 articles, there were 73 different definitions of implementation science. So several of them had more than one definition. And 41% of those were novel, so people just came up with their own definitions. So, but what I like to think of it is sort of exactly what was said, and implementation science is really to answer this question. How can we optimize evidence-based intervention in diverse, real-world, social, cultural, economic, geographical, and health systems, right? So taking something that maybe somebody designed or was designed somehow and putting it into practice, right? So it's taking the theoretical, putting it into application, or going from efficacy. They may have been a clinical trial done in very rigorous conditions. How do we put that into effectiveness, like in the real world, outside of a clinical trial? How do you take the evidence from possibly a randomized controlled trial and put that into practice in multiple clinics, in multiple settings, in multiple countries? So that's really what implementation science is. So it's a multidisciplinary specialty where you have a number of different people involved, right? You have different stakeholders, you have organizations, communities, individuals, and stakeholders. And what I want to highlight throughout this presentation and talk and discussion is where can we get youth involved in implementation science? And so this is one place, right? And identify youth as a key stakeholder in this, particularly for interventions for adolescents, right? So we want youth involved from the beginning and involved in what we're going to do and how we're going to do it. So they're our key stakeholders and getting them involved, all right? So when is a good time to use implementation science? Do you want to do it after the clinical trials are all done? Or do you want to start at the beginning, somewhere in the middle?
What do you think, Dr. Inani?
That's an interesting question because when you look at things like acceptability or feasibility of a particular intervention, it might not necessarily be based in clinical trial evidence. So I think about implementation science studies, including those that don't necessarily have an established evidence base, but I'm not sure if that's formally implementation science.
Yeah, so oftentimes people think of it as something to happen afterwards, right? So you've already done your clinical trial, you already have evidence, now let's start the implementation science part of it. But really it should be involved from the very beginning, right? So exactly as Dr. Anane said, we should think about it even when we're designing the study and designing an intervention or designing a program to see about acceptability, right? Feasibility. Some of these things, if you design a great program or intervention, but then people don't like it or people aren't going to use it, or it's really too hard to do in certain settings, then it's not going to work. So starting it in the very beginning is very helpful. So we're going to go through an example and step by step from beginning to end of an implementation science study. This is one that I'm currently involved in. It's called INCHA VIP. So those of you that were paying attention yesterday, we talked about INCHA, which was our pilot study using an mHealth intervention. We're going to take that to the next step in this larger study where we're comparing the mHealth intervention to an in-person intervention that's quite similar. And so that's our INCHA VIP study. And we're going to take step by step, through this study, how did we use implementation science to design the study? All right, so step one, going from the very beginning, keeping implementation science in the very beginning, is to identify a gap in the literature or unanswered research question. All right, what are people's thoughts on that? Do people typically do that before they launch a study, or how do you go about doing that?
I see one over there. Brian, people are scribbling madly. Will people get the slides?
They should, Karen. Yes.
Say your name and where you're from, maybe.
Okay. Thank you very much. My name is Abbaine from Ethiopia. And actually, identifying the gap means that systematically reviewing different literatures or different articles. So, for the development of the intervention, generating evidence from different articles, or as it is mentioned in the slide. So after doing that, based on that evidence and supporting it with other theoretical or to see the behavioral aspects or other issues. So.
Yeah, I think you hit it right on. Is a great way to do that is start with a systematic review. Like, what do we know already? You know, maybe there's already been a study that has answered my question. Maybe there's already an intervention that has addressed this in another setting or even another disease process or something else. So can I find something in the literature that's similar to what I want to do or that has already answered my question? And maybe the answer to that question is no, there's nothing out there. Well, then you've got to start from the ground up, right? So that's what we did for our study. Step one was we did a systematic review, just as was recommended. So we looked at all the different interventions that were done in South Africa that addressed the continuum of care for adolescents with HIV. And the continuum of care meaning for all the way from being diagnosed, being linked to care, being engaged in care, taking your medicine, remaining in care, and being virally suppressed. So going all the way through the continuum. And so I won't go through the complete results, but some of the major findings from our systematic review is during transition for adolescents, particularly for adolescents with perinatally acquired HIV, transitioning from pediatric care to adult care, there weren't any evidence-based interventions. There were some programs, there were some people doing things, but there was nothing in the literature about evidence, nothing with defined outcomes. And then in all of the studies in going from step by step in the continuum, not a single study done in South Africa had any mention of costing. How much does it cost? So if you're going to design an intervention or something that is done in a country, you have to decide how much it's going to cost. Right? If somebody's going to take this up, usually the research is funded possibly externally, maybe the NIH, maybe the Gates Foundation or some other foundation that are paying for the research. But once the research stops, often that funding stream stops. So how are you going to continue to fund your intervention, particularly if nobody knows how much it costs to do, how much it costs to develop, how much it costs to deliver? So not in all of the studies that were just talking about the continuum of care in South Africa, none of them mentioned cost at all. So those were two pretty big gaps in the literature that we decided to target. So step 2 is to design or adapt an intervention to address a research gap or question. All right, so Dr. Adong mentioned this yesterday during her talk, it's better to find something that already exists than to start from scratch, right? See what's out there, and can you adapt something that already exists? Is there already an intervention that you might tailor to your situation or disease process or whatever question you're trying to ask? All right. So one way to do that is through human-centered design. Has anyone heard of the human-centered design before or used it? All right. Well, I like to say for adolescent studies, we should just cross out the word human and call it youth-centered design. Because I don't want to be the one designing the study. I want youth to be the ones designing the study. Right? If they're the ones that we're going to intervene upon, or they're going to be our participants in our study, they need to be the ones with the voice in what they want to do, what they think is going to help them, and things that they're going to be involved in. So we started our study, and so this is a nice figure that sort of describes what human-centered design is. But basically, it's involving the people that you're going to involve in your study or intervention or program, involving them from the ground up in how to design and build this intervention or program. Right? So we started with our sort of I don't have a pointer, but getting them in the bottom right-ish triangle here is getting them engaged. And so that's what we started with. So we engaged adolescents from the very beginning. We engaged caregivers and we engaged healthcare providers and went to them and said, what can we do to help this transition process? What are you interested in? And then once we had defined that and they gave us some ideas and things, then we sort of built on some existing programs, which we're going to go through in a bit. And then once we had sort of a pilot or an idea of an intervention, we went back to adolescents, healthcare providers, and caregivers and said, this is what, based on your input, this is kind of what we designed. What do you think? Do you think this will work? Would you do it? What do you want to change? What's good about this? What's not good about this? And then you iteratively change it and fix it as you go along.
So, Brian, I wondered if you could step back a little bit. You talked about identifying the gap in the literature, et cetera. Let's say they looked and there was nothing there. There's no data. How would you recommend someone go forward in terms of designing an implementation study? Yeah,
so if there's nothing, it depends what research question you're trying to answer. And so if you already have a good research question and there is nothing there, then I think you're wide open to do what you want to do. If you have a good research question and you have an idea what you want to do, but there's just no intervention yet to address that, then you want to look at there's probably something been done or some risk factors that you're trying to modify. And so you want to still try to find evidence base to target. What are you going to target? What are you going to improve? And that's part of designing your research question, right? So what is your question? What are you trying to improve? What's already been done to improve that piece? And then build on the theory, build on evidence that's already been before you. It's very, very difficult to start something from complete scratch. And I don't think in 2023 there's not many things that we can start from complete scratch. Even when we had a whole new disease of like COVID-19, a lot of that was built on other COVID research, other viral research that has already been done. So nothing really started from complete scratch, even when you had a whole kind of new disease out there. Any other questions, thoughts? We can take a nice pause here. All right, we'll move on. So you may recognize this slide from yesterday. So this was our original INSHA intervention. So it's an mHealth intervention. For those of you that weren't there or were asleep or not paying attention, it's an mHealth intervention, so a mobile phone-based intervention that was developed using sort of adolescent or youth-centered or human-centered design. It uses encrypted, closed group chats delivered via WhatsApp on the phones. And its goal was to target, so we had a sort of gap in the literature, but we also knew from prior research and our prior research that there were some goals that we wanted to target. And some of those goals were peer support and improved communication between the adolescent and their healthcare provider and the adolescent and their caregiver, and then also trying to not interfere with school too much. Those were our main targets for this intervention. And that was based on our prior research and on discussions with adolescents. And so our formative research, we gathered adolescents and healthcare providers and the adolescents' caregivers from a single site in South Africa. All the adolescents had perinatally acquired HIV. They were all disclosed of their HIV status, and they were all on treatment. We started with 20 adolescents, 10 caregivers, and 10 healthcare providers. And we asked them some questions about those gaps, about those targets, about peer support, about communication, about what topics they would like to learn about, what they think would improve peer support, what is the best delivery method. So as I said in the slide before, that this was a WhatsApp-based intervention, but we started from scratch. The adolescents actually told us they wanted it to be on WhatsApp. And some of the reasons, they said, well, if it's a whole, and we said, we could design a whole new app, we could use other platforms, we could use Facebook, we could use Instagram, we could use whatever. And they said, no, we want to use WhatsApp, because if I have a new or different app on my phone and somebody sees it, they're going to say, hey, what's that about? Right? And then I'm going to have to tell them, oh, this, or make up a story because they don't want to talk about, this is an app I use to talk to other adolescents that have HIV, right? So they said they want to use WhatsApp because everybody has WhatsApp and everybody uses WhatsApp. So nobody's going to question what the heck that is, right? And they said they wanted closed groups because they didn't want anyone else to be able to join or look or see what they're talking about. They wanted it password protected, so WhatsApp has that ability. So each of these conversations were password protected and closed, and they also wanted to use pseudonyms. So each person got to use their own and make up and create their own pseudonym. So all of these were all designed and ideas that were brought forth by the youth. So we came up with this sort of template as to what we were going to do. And we had modifiable factors from the SMART, which I'll show you, I think, in the next slide. So the SMART is the socio-ecological model for adolescent readiness for transition, which is a model to help adolescents transition from pediatric care to adult-based care. And there's these certain factors that they say are modifiable, things that you can target and identify and help improve upon to get adolescents closer to being more engaged in their own care and being more ready to transition to independent care and adult care. So a couple of those were like knowledge and social support. Based on that, we had these suggested modules or topics, and then some of the input I'll just show you in the next slide. So just as I said, the SMART is the socio-ecological model for adolescent readiness to transition. This is it. It's a little bit complicated, but there are some things that are harder to change. There's some things that are easier to change. We obviously wanted to target some of the things that were easier to change that are highlighted in the box there. And this, in terms of the SMART and all of this, it involves this combination and this discussion and this dialogue between adolescents, their caregivers, and their healthcare providers. So all of that helps to bring them closer to being able to transition to adult care. So we decided to target some of those, the ones that are highlighted, those modifiable factors, and all of those were things that adolescents or caregivers or healthcare providers said that are important to help with the transition, and think that they're not easily, but that they are modifiable and can be addressed. So these are just some examples that we used. So based on the SMART factor in the dark blue there, we had selected modules or discussion topics that would happen over WhatsApp. And then you can see there's illustrative quotes that adolescents said that they wanted, and that points to us. So I'll just pick the top one just so you go through it. So one of the adolescents said, I'd like to talk about the behavior towards taking ARVs since we have HIV. So they were asking about, they wanted to talk about, HIV education. And so that became a module. HIV education fits into the knowledge box in the SMART. And so that's how we designed this, and we basically ended up with 10 topic modules based on quotes from and input from adolescents, healthcare providers, and caregivers. All right. This is what we ended up with to start. We had different modules. We then theater tested it, which means we just delivered the pilot intervention in front of a few adolescents, caregivers, and healthcare providers, and got feedback and said, hey, this is part of it. This is our disclosure module. This is how it's going to run. And we ran it with them, and then we got feedback. What worked? What didn't work? What did you like? What would you change? They all, as I mentioned, that through this, they decided they wanted it to be in WhatsApp. They wanted it in closed groups. They wanted it password protected using pseudonyms. They wanted it to be done once a week to keep engaging care. So we had one major session during the week, which was the longer session, and then we had a brief check-in throughout. These were typically done on the weekends. On Saturdays were the main session and then like midweek after school, there was just a brief check-in to see how people were doing and to see if people had any questions or wanted to continue the conversation. And then caregivers were in a separate chat, and as we talked a little bit about yesterday during this discussion, the caregivers had sort of a brief check-in with them. They just introduced the topic that we were discussing each week with the adolescents and how to bring it up and some ways to discuss those topics with their adolescent. And so they knew what we were talking about that week. They didn't know what the adolescents specifically said. Of course, those were private. But we said, hey, this week we're going to talk about HIV disclosure. These are some ways that you can bring that topic up with your adolescent. This is somewhat of a complicated graph, but it sort of puts everything about our intervention all into one slide. And all the theory behind it, what fits the theory, and what we included in it. So the column all the way on the left is a 6-step process that is recommended. It's from the U.S. Task Force Health and Human Services called GOT Transition. And it's basically 6 steps that you should do to prepare an adolescent to transition. And so we have listed them there. The 2 main ones that we're targeting with this intervention were transition readiness and transition planning. We took those as part, and then the modifiable SMART factors, which ones fit into those boxes. You can see there in the modules, and then how we're going to deliver it. So with the content delivery, with the group chats, with facilitated discussions, with online meetups, and discussions, and then direct consultation with the healthcare providers, which I didn't mention yet. But that was another piece to it, is that we had an open link between the adolescents and the healthcare providers so that they could ask questions anytime they wanted to. So the way that we did that to decrease the burden on the healthcare provider was adolescents could ask questions, but then the healthcare providers would sort of answer all the questions at one time. Usually it was like Friday afternoons. They would answer all the questions that came in through the week. All right. Any questions up till there? So that's how we sort of took the theory, took the first step of human-centered design to design the intervention itself.
Thank you. My name is Anastasia Kumola from Nairobi, Kenya, from USAID. When it came to the youth-centered design or human-centered design in terms of involvement of the adolescents, maybe can you unpack what categories of adolescents did you engage, especially with regard to diversity, to input into this design? Thank you.
So your question is, what did we actually ask them? Or, sorry, what's the...
For participation of the adolescents. So who are these adolescents, the 20 or the 19 that you are working with? Yes.
Just who were they?
Like the diversity of them, were they primarily acquired? What ages were they?
Yeah, so they were they were the same ages and basically same demographics that we were targeting with the intervention. So these were all adolescents 15 to 19, which is what we're targeting with the intervention. They were all adolescents with HIV in care and on treatment, and they were all disclosed just because we were going to be talking about HIV. So from the initial development, it was all from one single clinic just because it was easier to access them. So there was one specific clinic in KwaZulu-Natal, South Africa, but they all met the demographics of what the intervention was targeted at. And then once we had that was the basis that we started it, then we opened it up to other clinics, but again, we kept with the same demographics of the people that were targeted with the intervention.
Thank you for the question. My name is Kae. I come from here, Zambia. I work for CIDAS. So in your previous step, I saw it looked more of a focus group discussion where you want to get something from adolescent, and it looked like you are only working with those who, the end users of the strategy that you are coming. But I did not see any policy maker, any government official, for instance, in that group. Was it intentional, or that's the procedure?
No, I mean, that's a great question. And that, so for those of you who didn't hear it, so the question is, you didn't include any policymakers, and that's a very important point. And we did not, mostly because it was just difficult to access them at the time. I think it would have certainly been a benefit. We didn't include them in the study itself, but they were included in the process. So when we were building this, we got input from some of the Ministry of Health in the KwaZulu-Natal saying, if we build this, is this something that the Department of Health could support? And so they did have their input from the beginning, but we didn't get specific. I think that would have been a great thing to include, but that we did not include. But they were involved, but not in the research part. Like, we didn't put them in a focus group, but they were involved from the beginning.
Oh, sorry. Oh, I'm coming. You're making me work.
Sorry. So my point was, what is really acceptable for youth is not always acceptable for policymakers. Like, I'll give you an example of a country like Russia, for instance. So you wouldn't gather youth and tell them what they feel about this intervention. Then tomorrow, with a conservatist, or these guys who have their values that youth are always not aware of. So you may bring an intervention, then get to a point where it blocks because the policymakers tells you, here, we don't do this. Like here in Zambia, it's a Christian nation in the constitution. So you can come up with something, then you get blocked at some point. They tell you this can't be implemented. Thank you. That was the real rationale.
So part of that was done with, so we had healthcare providers. They were all working in the government sector. So they were able to answer a lot of those logistical questions. Can we do this? Is this legal? Is this ethical? Is this something that is likely feasible to be done in your clinic, or would you do this? So we did have healthcare providers to sort of answer those logistical questions. But I think you're absolutely right. It would have been great to even have people from the Ministry of Health involved in those discussions.
All right. So my name is Felix. I work for Elizabeth Glazer Pediatric AIDS Foundation in Malawi. Looking at implementation science from where I'm standing, it's really a great approach in terms of enhancing acceptability, because we're getting input from those who would eventually be the end users of the products or the services. Now, going back to adolescents and the debate that we had yesterday about consent and things like that, how did we sync with the reality that these adolescents would also probably get support from parents, and that parents who have been taking care of them throughout would probably also have like variable input into the whole program. So how did we create opportunities for us to be able to sort of like incorporate input from the youth, but at the same time take on board experiences from parents in terms of what they would have wanted to actually teach their children, so that by the end of the day it's more encompassing?
Yeah, so great question. And we did include part of the discussions. As I said, we had the 3 tiers. We had the adolescents themselves, we had the healthcare providers, but then we also had caregivers. So that was their parents or guardians. So they were involved in the very beginning as well. So those same discussions, yeah.
I think in addition to that, I think the other question you oftentimes get when you talk about adolescents, that these are the low-hanging fruit adolescents, right? The ones that are in our clinics.
They're already in care, yeah.
Right? What about those ones that are not, and how do we engage them in terms of what their inputs would be? And I think that's something I always get. I wonder what your thoughts are about that.
Yeah, and so one of the things I always say about that is it's really hard to get adolescents that are not engaged in care. I mean, they're just hard to find and hard to get. But the simple answer to that question is a lot of people think adolescents are, this one's engaged in care and this one's not engaged in care. But really, it's a spectrum. And when we actually looked at the adolescents there, there were times that they were engaged in care, there were times that they weren't engaged in care, there were times that they were virally suppressed and times that they weren't virally suppressed. So, if there are people permanently out of care, that's kind of a different demographic. But in reality, most adolescents are in and out of care. And we did capture that because the adolescents that we sampled were kind of just normal adolescents that were all in and out of care.
Yeah, my name's Tembo Champion from Zambia. I'm Amico National Chairperson. Amico is a body that is dealing with HIV for mayors and council chairpersons in the country. I want to comment on the question that was given, which was saying, did the research incorporate the policymakers or the politicians? And I think the answer was, it was a bit difficult to get them. I want to say that in Zambia, Amico is represented in all the 100 districts of Zambia. Amico is working very closely with Ministry of Health on HIV and AIDS. Amico is ready to make available its network that includes district substructures for any programs related to HIV and AIDS. We are policymakers, and we can help all forms of interventions within our communities if you want linkages with people at a higher level than ourselves. So that should be easy to work with. Yeah. Thank you very much.
That's a great research. So part of it was also the timing. I didn't mention that. So this was like 2020, and so a lot of people were busy with COVID, and to come to an in-person interview was challenging. We did do some of these virtually, or they were in the same building, but they were kind of kept in corners. It was challenging times. But yeah, so part of that was not that they didn't want to be involved. It was also timing and challenge. But it's great that there's a resource here in Zambia. That's fantastic. Yeah. All right. Oh, one more question.
My name is Louis Mercy Katoka from FHI 360 Zambia. So in your presentation, you did highlight that adolescents were engaged in focus group discussions and all that. But then my question is, were they also engaged in the prior steps, the identification of the gaps, as well as the design or the adaptation of the intervention? And what exactly did you do to ensure that they are supported for them to meaningfully contribute towards the process? Yeah.
Yeah, so as I said, we didn't completely start from scratch. We had about 5 or 6 years of preliminary research to help guide where we want to target and what aspects we want to target. What are challenges for adolescents transitioning to adult care? What are sort of the facilitators, and what are some of the barriers? So we had that to start with. And then we asked them about those specific barriers. And really when we started this, as I said, we really started from a clean slate. We did not have an intervention and said, hey, this is what we want to do. What do you think about it? We started from the ground up and said, what do you want? So the adolescents were the ones that really helped design this from the ground up. And they said, we want peer support. We want to do it The only sort of stipulation is that we said we wanted to do it, via mHealth, because we had already done some in-person ones, which you're going to see in, I think, the next slide, or a couple slides. But we already had an in-person intervention that was similar, but we sort of, again, started from scratch and said if we wanted to design a digital health, a cell phone-based, an mHealth intervention, what would you want, what would work for you? And this is what we came up with. So it was, we came up with it in collaboration with the adolescents, with the healthcare providers, with their parents and guardians. So it was a group of everyone coming to the table at the same time.
I'll go there first.
Okay, thank you so much. Ashono Evelyn from Kenya in one of the USAID funded projects. So just a question related to what you've presented, which is very good. So far I've not had the arm of the education, that means the teachers. So were they involved? And in addition to the teachers, the religious fraternity, because these adolescents are interacting with so many other players within the community. And you realize that teaching, or rather the teaching fraternity, the adolescents interact with them at that age group for a longer time even compared to their parents back home and all that. So how did they come into play into this model? And also the religious fraternity, which also plays a very important role in molding these adolescents.
Yeah, I think that's true. But we did not include them for the purpose of, we wanted it to be a closed group. And given that there's issues with disclosure and health status and things like that, we kept it a closed group and did not invite other people. So the teachers were the research coordinators. So I'll get into where the kind of information came in a couple slides. But we did not include religious organizations because we didn't really want that adolescents to have to disclose their status to people outside of healthcare. That was the main.
So I think these are really important points, though, because what basically everybody is talking about is how all the things feed into what happens in the process. And then as a researcher, you have to decide which parts am I going to intervene on in my implementation science study or what have you. So, you thought about it, but then said, we're not going to for this reason. So I think coming up with your framework and then saying here, 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 and understanding what you're going to do and what you're not going to do, but acknowledge what you're not going to do, I think is as important as what you're going to do.
Yeah, and it's also an important piece is you really, as you want to try to do everything, you can't do everything, right? There's not one, as I sort of said, also I'll quote Dr. Adung yesterday, mHealth isn't a silver bullet, right? And I had this discussion with several people also yesterday, it's a piece to the puzzle. Right, it's something to help keep adolescents engaged. You're not going to be able to answer. I mean, we saw all the barriers today this morning, right? This doesn't help, gender-based violence that well. We also do discuss that in one of our modules, but it's not going to fix it, right? Even adherence and some of the things we actually try to focus on, it's unlikely that a text message session for a couple hours once a week is going to fix all the problems, right? But in combination, can we help them get a little bit closer to the goal? And that's really what we're trying to do. And as we were building this, and I said, a lot of times we're focused on what the content of the educational information was. A lot of times I'd back off and said, the content's really not that important. What we're trying to do with this intervention is build peer support and build communication skills and communication between the adolescents and their caregivers, adolescents themselves, and adolescents and the healthcare providers, right? So the content was less important. Of course, it has to be factual, it has to be accurate, and it has to be something that they're interested in. But like the exact words and exactly what it was, to me, wasn't as important as it's the process.
Okay, thank you. Thank you so much. As I mentioned, my name is Abbaini from Ethiopia. And I have one concern related with eligibility or including your study participants. Just I'm thinking that there may be the literacy issue, especially e-health or digital literacy to communicate with WhatsApp. So how did you manage it? Such kind of issue, as well as economical aspect you have mentioned, one of the issue is that during the implementation, the policy makers, I mean the implementers, and other issue related to the economy will be raised. So how did you manage it in the issue of economical, especially the porn or availability of the porn? And also literacy.
That's a great, so 2 questions. I'll answer the economic one first and then the literacy one second. So economic one was something we also considered. And in an original design of the study, we actually said, well, we'll give cell phones to all the kids so that, so that everyone can be involved. And then we thought about it some more, going back to kind of the policymakers is, are policymakers going to take this up if we provide cell phones to everybody? No way. No, they're not going to buy a cell phone for every kid, right? So we actually took that piece out and said, no, we're not going to provide cell phones because this is an implementation science study. We want to see, does this work in the real world? And in the real world, nobody's going to buy you a cell phone. So we enrolled you. You only had to have access to a cell phone. So if it was a share phone or your parents' phone you could buy, then they were enrolled. And then we did give them data. So data was loaded onto their phone about an hour before each scheduled session. We gave them a lot of extra data, somewhat as an incentive, but it was well beyond what they needed for the session, so it sort of acted as a little bit of an incentive as well, because then they could, play on YouTube or whatever they wanted to do afterwards. And then the last thing was literacy. So they did have to be literate, but since they were texting themselves between each other, they could go between, this was in South Africa, so they could go between, this is Zulu and English, however they wanted. A lot of times it was just emojis going back and forth, so they were speaking their own language. So if they were completely illiterate, they wouldn't have been able to participate just because they couldn't read. But at this, that never actually came up. We never had an adolescent in any part of the study that couldn't read a text message. All right, we're going to move on for time, but this is a great discussion. So the next step, step 3, is to design the implementation study, right? So we talked about designing the intervention. Now we have to design what we're going to study. And so this is a graph that just shows kind of the traditional pipeline of implementation science studies, and it goes through several different ways. But usually you think about what we've sort of talked about was, designing the intervention. That's kind of the gray box, or pre-intervention is designing it. And then you usually do an efficacy study, a controlled trial or randomized controlled trial. And if that shows promise or shows that it works, then you would go into an effectiveness trial where you sort of bring it into the real world outside of clinical trial settings and restraints. And that's where a lot of times implementation science happens. And this graph just uses the EPIS framework, EPIS, which stands for Exploration, Preparation, Implementation, and Sustainment. So those are 4 different, we're going to talk about frameworks in a bit, but those are 4 different boxes you can put things into when thinking about an implementation science study. Those are all important aspects you want to think about. And so we, at this point, had 2 interventions. I didn't talk about the other one, but we had an intervention that used in-person, adolescent-friendly clinics, which really targeted these same aspects of peer support, communication, and trying to avoid interfering with school. So those were our main things that we targeted. And we showed some efficacy in that study, and then we had this study which showed, in a pilot study, some preliminary efficacy on retention and care. So we had 2 interventions. We had some hints of efficacy, I would say. And so now we had to design our study. What are we going to look at? And so this is just a list of 6 different types of implementation science studies. You can do a cross-sectional study where you just look at one single point in time. You can do an observational study where you sort of say this is time 0 and we'll go forward, and possibly that can be a pre and post, so you can look at before the intervention and then after the intervention. You can do an experimental design where you have a control group and an intervention group. Or you can do a hybrid design, which is combining an efficacy trial or effectiveness trial with implementation science outcomes. You could do a cost effectiveness study. You have your study and you really just want to see how much does it cost. And you can do some qualitative research, particularly those are typically about acceptability and feasibility, stuff like that. So we chose a hybrid design. So I'm going to go through, does anybody know what hybrid designs are? I'm going to go through it. All right, I'm just going to move on. So hybrid designs, there's type 1, type 2, and type 3. I like to think of it as like a kind of a pendulum. So type 1 really focuses on the clinical outcome of the intervention, so like an efficacy or effectiveness trial. So you're really looking at, does my intervention work? That's your main question. And then as a side question, you're thinking, well, what are some of the ways that we can help push this intervention along? So those are your kind of implementation science questions. But your main focus is, does it work? And then I'm just going to jump to type 3 because that's the other side of the pendulum. We have an intervention. We know it works. We've got a good intervention. There's been efficacy trials. We've done it. What we want to know is, how do we implement this? So my main question is, what are the implementation science factors? And then efficacy is kind of off to the side, right? And type 2 tests both at the same time. You're going to test the study itself. Does this intervention work? And what are the implementation factors? Or can we test an implementation science strategy to help improve that? So you're studying them both at the same time. So those are the types of hybrid designs. So this just goes through a few examples. So your aims are going to be somewhat different. How you design the study is going to be different. What you compare is going to be different. What you evaluate is going to be different. And what you sort of measure are going to be different. So type 1, it's the effectiveness of, as I said, the effectiveness of the intervention. And then secondary is to understand the context for implementation. The randomization can either be the patient themselves or a clinical unit or a clinic. Often it's compared to standard of care or placebo. The evaluation is usually mixed, quantitative, because you're going for efficacy or effectiveness. Quantitative is usually the first, and then there's usually mixed methods and qualitative, often interviews, to get some of the implementation science questions. And then jumping to 3, it's kind of the opposite of that, the other side of the pendulum, whereas you really want to determine the utility of an implementation strategy. We're going to talk about what implementation strategies are in the next group of slides. And then as an aside, kind of a secondary analysis, you're going to look at the clinical outcomes, right? So this time when you randomize, it could be to the provider, to the clinical unit, to the facility or system, but typically not the individual, because you're doing an implementation strategy that you're testing, not an individual intervention. And so comparison is often to standard of care or possibly another implementation strategy. Usually because of just the nature of what we're measuring, these are usually mixed method studies, with the quantitative stuff being your secondary outcomes. And then a hybrid is just you're mashing the two together, right? So it's both the same at the same time, essentially. You're basically doing a type 1 study and a type 3 study at the same time where you have equal outcomes. So the co-primary aims are effectiveness of the intervention and then the feasibility, utility of the implementation strategy. So for our study, we chose a type 1 design. So really we were looking at, because the intervention itself hasn't shown to be, there's been a hint in a small pilot that it may improve retention and care, but we want to prove it. So our primary outcome was effectiveness. So this is a type 1 study. And then secondary aims looking at the context for implementation. So what are the factors, if this works, what can we do to make other clinics take it up? What are the factors that can help it along? We randomized it at the clinic level, so it's a stepped wedge study design. So each clinic will get either the in-person intervention or an mHealth intervention, and they'll be randomized to either getting it immediately or delayed. And then our outcomes we'll go through in a bit. But the primary outcomes, I don't know if I can go back. Yeah. Our primary outcomes were retention and care and viral suppression, where our secondary outcomes are the implementation factors. We'll go through all of them in a bit, but acceptability, feasibility, sustainability, some of the barriers and facilitators to implementation, and costing. As I always like to point out, where can we involve youth in this process? Well, in all of those, in our evaluation and in our measures, we get input from youth voices, right? So in the qualitative interviews, we're getting input from the youth in some of the questionnaires we give about acceptability, about feasibility. They're answering those questions. So there's youth involvement in this step as well. So this is just the design of the study, so you can figure out kind of what we're doing, how we're doing it. So it's done in a total of 16 clinics. Each group of 4 clinics has 2 urban, 2 rural. All this is done in KwaZulu-Natal, South Africa. So they get screened, they get seen if they are already ready to transition by a transition readiness assessment. Then they get enrolled. The clinics are randomized to either immediate intervention or delayed, and they're either the in-person intervention or the mHealth intervention. And then after 9 months, those that were on delayed intervention get the intervention, whatever one they were randomized to. So we end up with 16 clinics, all get an intervention. Half will get the mHealth intervention or INCHA, and the other will get the in-person adolescent-friendly clinic service intervention. And this just shows you what we're comparing. So at standard of care, these are ones with delayed interventions. They will go to clinic on the weekdays. They will collect at the regular clinic pharmacy. They'll have access to individual counseling. They're not going to have any external additional services, but all the staff is going to be the same staff, and all the staff will be trained in adolescent-friendly services. And then if they get enrolled into the in-person intervention, that's going to take place after school hours. They're going to be able to pick up their medicine after school hours at the clinic. They're going to have these in-person group discussions, usually have social activities. Usually they get a meal as well, typically lunch, and it's the same staff. Those that get randomized to the mHealth intervention, these happen after school hours. They'll pick up at the regular pharmacy. And then they'll have these virtual discussion groups in online chats. They'll be able to message the clinicians. They'll be able to get appointment reminders. And the caregivers also get additional training. All right, so any questions about designing the study or hybrid designs or other types of designs? All right, so the next part is what I said, the other piece. So, the intervention itself and sort of all we talked about up until now was really about the effectiveness of the intervention. Now, the next step is what about the implementation strategy? Tell me what's an implementation strategy or an example? Anybody know what that is?
I'll give it a try. So for example, for one of the studies we have at CIDAS, and one of the implementation strategies I can think of right now are standard procedures. So the implementation strategies may involve how you're going to proceed with recruitment, site partners that you want to involve in, and how you're going to do retention. So it could be different steps, I think.
Thank you for trying.
Yeah, so a lot of that is involved. Anyone, any other thoughts? What are some possible implementation strategies?
Just in line with what she said, I want to believe implementation strategy, these are just standard procedures that one would undertake if they're to maybe bring to effect and maybe a particular agenda, or I would say a particular goal that you're actually working on. Okay, in short, these are just standard procedures that one would actually put in place to put to effect a particular agenda.
Yeah, so you're kind of on it, but it wouldn't be a standard. You want it to be a standard procedure in the future, but it's not a standard procedure now, right? But the other part was right. So it's something you're going to do different, right? So it's how are we going to get this intervention delivered differently? We're not just going to say we created this intervention. Here it is. It's right here. Here's my intervention. Go for it. right? That's not going to work. Nobody's going to do it, right? So we have to have an implementation strategy. All right, so what is it? Really, it's just a method or technique to enhance the adoption, implementation, or sustainability of a clinical program or practice. So we have the intervention. How are we going to deliver it? And so to look at the components of the strategy, there's these different factors. You look at the actor, so who's going to carry out the intervention, the action, what specifically are we going to do? What's the dose? How intense is it? So this is, is it going to be done weekly? Is it going to be done monthly? Is it going to be done daily? How often is it going to be done? What's the timing? What's the temporality, right? So is it going to last an hour? Is it going to last 5 hours? How long is it going to last? And then what's the target? What's the target of our intervention? Is it the adolescents or is it the clinic? And that's something often difficult with this is separate from your intervention, and a lot of times this gets confused. A lot of students confuse this. So your implementation strategy is often not directed at the adolescent, it's at the clinic, right? So what's the clinic going to do to deliver this strategy? What are your implementation outcomes? That's the kind of next set of slides we'll talk about. And then what's your theoretical justification? How do you justify that this particular strategy will work for this intervention? So thinking of that, what are some common implementation strategies that have been used particularly for people with HIV? Can anybody name one or a couple?
Let me try again. I think one of the things, I don't know much about HIV myself, but I think one of the things they've done is improved the medication by reducing the number of medication they have to take daily. So they've reduced to, I don't know before how many they used to take, but it's now once a day at a particular time. I think that's one of the things.
So I would fit that into the bucket of simplification, right? Yeah. So we make the treatment for them easier. Right? So that would be an implementation strategy. How do we make this easier for
them? So with us in South Africa, I'm not sure about other places. In terms of HIV, they allow patients to now collect their medication from pharmacies. So instead of visiting the clinic on a regular basis or after every 3 months, we can just go to the pharmacy and collect after 6 months, whereby you don't have to stand in long queues. So that simplifies the entire process.
Yeah, that's another way to simplify. It decreases transport, it decreases time in queues. You just go to your local pharmacy that's right down the street and pick it up. So yeah, that would be another thing.
Also in line with what he just said, for adolescents living with HIV in the communities that I'm currently working in, we have a group of peers that are responsible for each and every HIV adolescent. So when they communicate with them on the day of pickup, when the adolescent feels they're not in the mood to come or they have difficulties coming to the facility, the adolescents take the responsibility of going to take the medication to them and making sure that they stay in care. Another one that I can easily think of from the top of my head is linkage to care. We find in the communities there may be some adolescents that may have been on care but may have fallen off for different reasons. So strategies such as linking our defaulters back into care is one of the strategies that is working very well within our communities.
Yeah, and so that one falls, both of those can fall into peer navigators, right? So using a peer to help navigate the system, bringing them into possibly the intervention. So yeah, those both have been shown to be effective.
So one strategy I can think of is the use of community health strategy. And I saw that working quite a bit, especially during COVID-19. And so we had community health workers going to the communities, talking to people, and just reminding them to go for their ART medication refill. So the community health strategy could be one of those that is
bringing in the community, working with community healthcare workers. So yeah, there's so I have a huge list of different ones. I think a lot of them ours touched on some of the strategies, but there's service delivery, which we talked about some of them, simplifying medicine, outreach, peer navigation would fit in there, decentralization that fits into decentralizing the pharmacies, getting it closer, mobile testing, point of care testing, all of these things helping with linkage to care. So all of those have sort of helped in the service delivery aspect. And then there's the infrastructure, task shifting, focusing on guidelines, healthcare worker or community healthcare worker training, counseling, social behavior, social support, which we talked about. Peer navigation often usually fits that bucket too. Using technology like reminders, cell phone reminders, text message reminders, and then creating demand. So this is often a big one for interventions where you have incentives, either financial, community mobilization, food supplementation, or behavioral economics to help get people interested in whatever your intervention is. So we really focused on these three main interventions. So healthcare worker training, and so that's going to be adolescent-friendly services for everybody, including those in the delayed implementation. There's quality improvement, where we look at the intervention and do fidelity checks called audit and feedback. So we see how the intervention's been developed, how it's been delivered, and we have a checklist. Did they do this, and this? And if they didn't, we go back and say, no, this is how the intervention's supposed to do. And then we have peer support. And again, this is something where the youth can be involved for this implementation strategy, where we sort of have champions to help enroll and stay engaged in care. So each sort of these closed groups is going to have an elected champion that is going to serve as kind of their peer navigator for their own group. All right. So any questions about implementation strategies? So the important thing when you're thinking about implementation strategy is that it's not the intervention itself. It can be if you're doing a type 3 design, but it's separate from the specific intervention. So usually you have an intervention and an implementation strategy. All right, next step is to identify an implementation science framework. And this is what a lot of people think implementation science is all about. I don't think it's what it's all about. It's a piece of it. But this is what people identify as implementation science. These are all those crazy acronyms, right? So just taking a step back, thinking about implementation science studies before we get to frameworks, because everyone talking about implementation science studies is what they focus on. But how did we get here so far? We looked at what's the implementation gap. So what intervention is not being delivered? So in our case, nothing for transition care. What are the constraints? How do you bridge the gap? So we are going to try to bridge the gap by comparing, is this better to do it in person, or can we do this virtually through mHealth? And what's your strategy? So what process is going to be used, and what framework are you going to use to study it? So when choosing a framework, make sure it's appropriate. Make sure it's familiar, that you've possibly used it before or others have used it before. You can adapt it to your needs. It doesn't have to be exact as to what other people have done before. And then make sure you have standard measures, like how do you measure it? A lot of people, when they come up with an implementation science study, they follow one of the acronyms, but then they never really say how they're going to measure those things. And that to me isn't a great implementation science study if you're not going to tell us what you're going to measure. So this is the list, the giant list of all the different, not all, there's even way more than this, implementation science frameworks. They're all sort of acronyms. There's many of them. These are kind of some of your most common ones. Probably the top 4 or 5 are on there: CFR, RE-AIM, EPIS. Those are kind of your top 3 probably. Frameworks, and basically what a framework is, it's just a way to think about how you're going to deliver an implementation science study and what you're going to measure. A lot of people get very tied up in what framework they're going to use, but I think you can just use the framework that's going to fit your study the best. And the way I think of it is, particularly when you're like writing a grant, because that's where the framework comes into play the most, is if I'm going to write a grant, I want the reviewers to say, oh, he thought about this. You know, this study team, you know, they put work into this. They've hit all the pieces on the framework. They're going to measure all these things. And so that's really what a framework is. It's a way to say, hey, I thought about this, right? And this is how we're going to measure it. So we chose REAIM. So REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So it's just an acronym that says that you thought about these things, right? And then, but that's not the end. A lot of times people say, we're going to use REAIM, we're going to measure these things, but that doesn't tell me anything, really, right? You've got to figure out what's your outcome, and who, and what are you going to measure, and how are you going to measure them? So I think that's my next, slide. So, so for this slide, don't worry about the outcomes or participants, just worry about the first column. So REAIM, we're measuring reach, effectiveness, adoption, implementation, and maintenance. We'll talk about how we're going to do that here. So that's the framework. But now you've got to say, within that framework, what are you actually going to measure? Right? What are you going to put in your database? What are you going to ask questions about? And that's what implementation science outcomes are all about. So this is a list of common outcomes. So we talked about some in the beginning. I think we hit upon acceptability, feasibility, sustainability. We talked about cost, fidelity. So we hit most of the common ones that are measured. Then there's obviously service outcomes, where you want to see, does this work? That's kind of your hybrid designs. Are you going to measure efficacy? Are you going to measure safety? Are there side effects? You know, if it's a medication or something. And what's the timing? And then client satisfaction outcomes. You know, did they like it? Did it work? Would they use it? What would they change? And how did this intervention change, you know, their life or their outcomes? So these are some common implementation outcomes, what you measure and how to measure it. So acceptability, we talked a lot about. A lot of times that's done at the provider level or at the patient level, and can be done through qualitative questionnaires, focus groups, or questionnaires where you sort of tick a different questionnaire. There's acceptability specific questionnaires. Adoption, that can be measured a number of different ways at the provider level or at the organization level. How was the intervention taken up? And it can be sort of measured in the beginning when you're about to launch it, or at the end, how many totally took it up. And it's often done from administration data or registration logs, things like that. Appropriateness, that's kind of similar to acceptability, can be done through questionnaires, often done very early. You don't want to find out too late in the game that, you know, participants or whoever's delivering it didn't find your intervention appropriate and they don't want to take it up in the future. So that's something you always want to measure early. Feasibility, again, you want to measure early, because if you have this huge and complex intervention that might work really well in a clinical trial, may not work in real life because it's just too complicated. So you want to find that out early on. Implementation costs, so this is about costing, cost effectiveness. How much does it cost? Are you providing incentives? You know, for your peer navigators, are you paying them? And how much, and what does it cost? Penetration, how well does it get? And are you able to do this? And you sort of look at this at the organization level. This might be, can you deliver this in an urban setting, in a rural setting? And then sustainability, you want, that's sort of at the end, right? Did it work in the beginning? Does it still work in the middle? And does it continue to work in the end? And does your implementation strategy feed off of itself? And does it keep working, or does it need maintenance to keep going and going and going? So now this is sort of our big table of what we measured in our study. So we used REAIM, right? That was what our framework, and then we take the framework to what is our implementation outcome. So for REACH, we're measuring acceptability. We're doing that via called the AIM acceptability implementation measure, which is a 5-question questionnaire, Likert scale. So they just tick it, and the adolescents will fill that out, and the healthcare providers will fill that out at 9 and 18 months. We're measuring effectiveness. We're looking at retention and care and viral suppression. We're looking at adoption. What is the enrollment? Are we able to fully enroll the study? How quickly can we enroll the study? And do those that are enrolled, do they continue on in the study? So we want a participation rate of about 70% is our goal. Implementation, we're measuring fidelity. So that was mentioned in the beginning. So you want to measure, because we're delivering this in 16 clinics, a clinic in northern KwaZulu-Natal may be very different. They may be doing the intervention quite differently than one, say, in downtown Durban. So we want to measure, are they delivering it the same way? So that's why we came up with a fidelity checklist and said, if you do this, 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 and this, then we think you're doing the intervention how it was designed and how it was intended. And that's implementation. And then maintenance, we're measuring costing. How much does it cost? In terms of time, we're doing time and motion studies where we measure the time to train the individuals to deliver it, the delivery of the intervention itself, and then the time the adolescents participate as well. So the total costing in terms of money and also in terms of time. Completion thresholds, how many get to the end of the intervention. And then sustained effectiveness, we're looking at all of these outcomes up to 2 years. So we figure if it's still going at 2 years, that shows some sustainability. Question?
Now I was going to ask 2 questions. So one, what do you recommend in terms of picking the time points? Like, why did you pick 9 and 18? Was a 1. And the second question was in terms of fidelity. How do you ensure fidelity, particularly when different clinics and different staffing structures and may not be able to do it the exact same way? And wonder what your thoughts about those.
So we're measuring. So the main reason that we're measuring it at 9 and 18 months instead of something 6 and 12 or whatever is because it's a stepped wedge design, and our statistician said that's the easiest way to do it. But yeah, it usually has to involve with what are you analyzing, what's your power, what's your statistics, and are you going to be able to show a difference? And that's because it's a stepped wedge design with 2 different steps. That's what our statistician told us. And sorry, what was the other?
The second one was fidelity and being able to deliver it with different staffing infrastructure at different clinics.
So that's to something like this when it's, when you really want to measure, a lot of times in a clinical trial, you measure it in one clinic to say, does it work in these rigorous conditions? In implementation science study, you want to say, can it be done in a lot of different areas? And so that's why we're doing 16 clinics, some rural, some urban. And so how do we know that that clinic in northern KwaZulu-Natal is doing it the same way that we're doing it in downtown Durban, where we designed the study itself? And so we came up with something called a fidelity checklist. And so we go through the main things that we think are the most important to deliver. And so each time the intervention is delivered, either the in-person or the virtual one, it gets recorded. So the live ones are audio recorded. And so we make sure that they hit the important topics. And they're going to go through the transcripts. And then for the mHealth ones, all of obviously what is sent on messages is also recorded, and we go through that and say, did they hit this topic? Did they do this properly? Was the timing correct? So we go through this checklist, and then part of that I actually didn't discuss, but part of our implementation strategy is what we call audit and feedback. So part of that is we're going to go through that fidelity checklist, and when they don't hit those targets, they get retrained. And then so hopefully the next time they deliver it, they do hit all the measures. And so each time it's delivered, we go through the fidelity checklist and then have an audit and feedback. All right, it's getting towards lunchtime. So in summary, our 6 steps to design an implementation science study. So identify the research question, design and adapt an intervention to address the question, design an implementation science study, how are you going to study it, identify the implementation strategy that you're going to use to deliver it, identify implementation science framework so you can think about all those boxes you want to include, and then identify implementation science outcomes that are going to map to that implementation science framework. And then if you've done all that, then I think you've designed a pretty good implementation science study. If you're writing a grant, you include these 6 steps, people are going to say, yeah, they thought about that. It sounds like they did their homework and they know what they're talking about. So, and we've sort of highlighted where youth can be involved in all of these steps, right? From the very beginning to the very end, youth can and should be involved in all of these steps. And those are some of my resources. And these are just some of my collaborators, co-investigators, mentors, and mentees, all that have been involved in this study and in other studies that built up to this study, and the funders. We can open it up to general questions. We still have about 10 minutes, so if folks want to.
Thanks for all for being such a good sport and all the letting us pick on you, but all the discussion has been really great. Your name and...
Thank you. So my name is Ali Roshni, and I'm currently working with Dr. Lona Tosca at UCT doing some research on gender-based violence and HIV in young mothers. So maybe this question is less applicable to a study like yours, because it sounds like you were really careful to involve young people in every step of the process of design and implementation. But I'm kind of wondering, how do you implement interventions in a way that is truly cognizant and respectful of local knowledge? Because I think sometimes it can get erased when people are swooping in from outside and trying to intervene, as it was. For example, I did a lot of work in rural India, and midwives are trained to be able to figure out what stage of pregnancy a woman is in just by touching her stomach. And obviously that's not as accurate as an ultrasound, but it is amazing that they have that intuition. So how do we do research in a way that's not patronizing, but is respectful to all those things?
Yeah, the main way is to just involve them from the very beginning, right? That's and it should always be done. And that's why I was like, we sort of mentioned human-centered design. Whatever intervention you're addressing, you would involve the people. So for this one, you would involve midwives and say, what we want to do is train you better on this palpation, or how can you also use whatever your intervention is going to be. But you would use them as the starting point. So using human-centered design. In adolescence, I say youth-centered design, but for this, it could be mother-centered design, whatever. But whoever the intervention is targeting, start with them. And then if you start with them, if you include them in the beginning all the way through, you're going to usually, the things that could be culturally sensitive, insensitive, difficult, it should get brought up and addressed. It's much harder if particularly an outside researcher says, here's my intervention, I created this, I thought a lot about this, I've read a lot all about it, and I designed this, go do it. Then you're going to run into a lot of problems.
Oh, yep. I think that's right. I think you can have an idea, but you can't come in and just say, this is what I'm doing, because then you lose people before you even start. Good point.
Hi, my name is Ruben Kiptui from Kenya. I would like to know how you did your consenting and consent assent process during the theatering testing.
Yeah,
and then,
so...
Oh, sorry. And sorry about that. To my second question, where does the needs assessment fall in? Is it during identifying the implementation strategy or identifying the framework?
So the first question, the consenting. So we got informed consent and assent from all of adolescents, and we for the theater testing, if you were over 18, you consented for yourself. If you were under 18, you did assent, and then your parents consented for you. We actually, because this was a very low risk study, and oftentimes adolescents come to the clinic without their parent or caregiver. For the early formative stuff that were just interviews, we actually were fine, and our IRB was fine with verbal consent from the parents. So if the adolescent assented and they gave verbal consent either by telephone or however, that's how we did it. But to be in the intervention itself, we needed written assent from the adolescent and written consent from the parents. Second question was
needs assessment.
Needs assessment. Very beginning, I would say that's step 0.5 to 1, right? So that's part of developing your research question, is what are the needs on the ground, right? And what's the gap? What are you going to address? So that should be, even pre-step 1 or involved in step 1. So very, very early.
Yes.
So I'm just curious about the different approaches you've highlighted. Most importantly, the hybrid. is there any sort of like preferred or recommended approach? It does seem, from what I'm hearing, that the hybrid model may be the best, because then you're combining quite a number of, your research as well as the implementation science itself. So I just wondered, do you feel there's one that is better than the other? Is the hybrid model the best model that we can sort of adopt?
No, so I just, I wanted to highlight what we did. I wouldn't say the hybrid model is the best. It's whatever fits what you're studying, right? So we picked a type 1 hybrid because we have an intervention that has shown some preliminary efficacy, and we want to prove that it still works, right? It hasn't been studied in a rigorous clinical trial. Take something like long-acting injectable treatment, right? In clinical trials, that works really, really well, right? And we know that, and it's been proven. So I wouldn't really need to do a type 1 hybrid design for that study. But there's a lot of implementation problems or issues that we need to still answer about how do we deliver long-acting injectable medication, right? So that maybe you do a type 3 hybrid, or not even do a hybrid at all, because we know it pretty much works if done correctly. But what we want to study is, how do we implement it? How do we get this to a rural clinic? How do we get people interested in injectable or something like that? So it depends what you're studying. So it may just fit your study and where the intervention is along the way you're trying to adapt. A type 1 is good for an intervention that you're developing. Hasn't yet had hard data on how effective it is in a rigorous clinical trial, because then you can do a rigorous clinical trial in a type 1 study, but also look at the implementation stuff. And then, sometimes a hybrid design isn't perfect for everything. Maybe you just, maybe it's the finances or your funding constraints, and you can only do an observational study. You can still do an observational implementation science study. You can do a cost effectiveness study. You have an intervention, it works. Now you want to see, can we do this in a rural area? And that makes it much, does that make it more difficult? Or it was done in South Africa and I want to adapt it to Zambia. Will that still work? And what are the constraints and what are the differences? You may not need a hybrid design for that.
Yep, coming your way.
Hi, so I have a question about how do we set up a pipeline, for like implementation research, because I know that for the past few years, there have been a lot of projects here and there, like in the community itself, but they're pretty much like fragmented on certain subjects, and like they just get abandoned, after that one project, without getting synced to other projects of the same matters. So I would really want to know, at least at the community level or at first, like civil society, how do we set up like a pipeline, to sustain and keep this going?
That is a great question and a super important question. And so where are you from? Vietnam. So I have a great answer for other folks, not for Vietnam. So the NIH Fogarty has a organization called the Adolescent HIV Implementation Science Alliance. And part of them, there are regional ones, but they're all currently within Africa. So there actually is one in Zambia, Zahisa. I don't know if people have heard of it or involved in it, but Zahisa is an organization that is exactly that. It's a pipeline. If you want to bring up an implementation science research topic or idea, or bounce it off of people or collaborate with people, that's one. There's one in South Africa, which we call AHISA squared, because it's AHISA SASA squared. So AHISA squared is the South African one. There's a Nigerian one. There's a Central West African one. I think that's all of the regional ones. But currently for Vietnam or Southeast Asia, there isn't one. But I would say looking for local people that are involved in implementation science, and you could either create a network, or just informally, getting a group together. Now we do this, sometimes internally in institutions. We often have people that we bounce ideas off of and get ideas from experts that are not always involved in our study, but we just sort of collaborate or ask questions with, and that's a great way to sort of keep the something alive. And we sometimes have regular meetings of people with like-minded research that, you know, we're not on each other's grants or involved, but we sort of just bounce ideas off of. So that's always another good way to start it up if it doesn't exist.
Is there a collaborative or something where you guys meet regularly where he could attend to get some ideas? Yeah, I mean, just in terms of expanding.
Yeah, I mean,
reinventing the wheel.
so we're all, I mean, I'm in charge of the South African AHISA or AHISA Squared, and we invite people from all over. We have had people from outside of South Africa to see kind of how we do it and what is involved. So feel free to reach out to me if you want to see that, or I can link you up with some of the other regional ones if interested.
Yeah. So I know that like the funding is so important, and I know that in order for you to really sustain a pipeline, you need like NIH kind of size of a grant. I get that, but I feel like the question that I asked earlier was more geared towards like the strategies and like the visions and like the ingredients that you put into your own strategies that you could set up this pipeline, have a vision for it, you know, more on that, like a plan, because I feel like that it's something that is so important, you know, aside from the funding. So.
Yeah, so I mean, individually, there's a lot of implementation science training. If you want to sort of set up your own study or series of studies or get involved in implementation science, there's a lot of, you know, implementation science is still kind of in its infancy. It's been around for a little bit, but it's growing more and more as we start to think about this more. And so there are a lot of training programs and other things that you can get involved in if you personally want to learn more about implementation science. The NIH does fund one. It's like once a year there's an application for it. There's other ones. Johns Hopkins has a great one, and other, I think University of Washington has one as well. So there's different training programs out there for individuals who are interested in this stuff.
Any other questions? Oh, I see one.
Thank you. I just want to find out how long does this whole process takes translating evidence into practice? Because it seems like a lot. And how long did you take? And at what stage are you in your project? So, how did we get to this point? I would say it has taken probably 10 years to get to this point. It doesn't always take that long, but there wasn't a lot of information. We didn't know a lot. So we had to start with the needs assessment. What are the risk factors for adolescents to do well, and what are the risk factors that they don't do well, and what can help? And then to design the in-person strategy and do a study, and to design the mHealth study and to do a study. So that's taken a long time. And so this study we're actually just about to start. We've actually done all the training, and we're hoping to enroll our first patient in November. And it's going to be a 5-year study. So, but it doesn't have to take that long, but it can take that long. You can start a study, next week if you find an intervention you want to adapt. There's a lot of interventions out there that have shown to be successful and work in a clinical trial, and then have stopped or haven't been adapted to different areas. They were developed in the U.S. or in South Africa or in Nigeria, but not adapted to other countries. So those, you can do an implementation science study, set up for a grant at the next cycle if you find one and do it and get started. But if you're starting from scratch, it takes a long time.
I would say I agree. I mean, I think every year comes HIV and Adolescents, and people have done things, and there's some evidence there. And so it's just, what are you looking to do, and going through the steps. You can do the steps really quickly and then put something together. I think, what Brian's talking about in terms of transition is something that I think we didn't think we had to think about transition, because we thought kids wouldn't survive, and now they survive, and then now we had to think about it. So the data had to come to put together. But there are many other things, whether it's GBV or viral suppression or things, that there are evidence-based strategies that exist, and it's just what fits your context and asking the questions and plugging that into a framework and going from there.
There's some that are, there's PrEP, long-acting injectable PrEP. We know it works. Now, how do we deliver it? There's a ton. That's something you could do tomorrow. Right? There's stuff like that. So there's, there's a lot of things that are kind of ripe for the taking. There's other, behavior interventions that have been shown to work. Peer navigation was mentioned. That's been shown to work in a number of situations, but it's not been taken up very widely. So how do we increase? Is there an implementation strategy that we can use to take that forward, or is it always just it costs too much in terms of time or money? But is there a way that we can come up with an implementation strategy to, drop the cost in time and money and get more people interested in it? So there's a ton of things that have already been shown to be effective that can be adapted to implementation science. Want to end it there? That's a good place to end, yeah.
Well, give yourself a round of applause. That was great. All right.
All right, thanks all. I think it's lunchtime.
Yes. All righty. And I think next session after lunch starts
Is that so there's posters, odd posters, I think, at whenever, and during lunch, and then regroup here at 3, right?
2.
2, sorry.
2 o'clock.
2 o'clock.
All right. Thanks, everybody.